Welcome, and thank you for joining us today for the Future Direction in Cancer Survivorship Research webinar. My name is Jennifer, and I will be your WebEx host. Please feel free to contact me using the chat panel throughout the webinar if you experience any technical difficulties. Before we move into today's presentation, I wanted to provide a quick review of features we will be using in WebEx. This will be an interactive webinar, and we'll be asking a few poll questions throughout the presentation and using the chat panel to solicit further recommendations on priority areas. Please take a moment to answer the first poll question. While you take a moment to answer that question, we'll move into some other logistics. Please note all attendees have been muted upon entry and will remain muted for the duration of the webinar. Please submit your questions, feedback, recommendations, or comments throughout the presentation using the Q&A and chat panel and select all panelists from the dropdown. A moderator will facilitate these responses on your behalf throughout the presentation and during any Q&A portions of the webinar. Please note you may need to manually open these features using the floating navigation panel found on the bottom center of your screen. This webinar is being recorded and will be posted online in the near future. An email notifying once it's available will be sent out. And it looks like we still have a few seconds left on the poll, and it looks like a lot of you are answering those. Again, if you have any technical difficulties, please feel free to reach out to me using the chat panel. And with that, I'd like to turn it over to our speaker, Dr. Deborah Mayer, Interim Director of the Office of Cancer Survivorship.
Thank you, Jennifer, and thank you all for joining us today. We're giving you an overview of a workshop that we held at NCI on April 8th, looking at evidence-based approaches for survivorship care to identify the research gaps. What we're hoping to do today is to present that information and then to gather your feedback on the identified strategic priorities. So thank you for joining us and taking time to weigh in on this. Just to give you a little background, the planning committee is listed on the left, is both personnel from NCI and external Julia Rowland and Catherine Alfano, and Trish Silber was our facilitator during the meeting. And the agenda followed the keynote with Kevin Effinger, which you had a link on your registration page to actually listen to his keynote if you took the time to do that. If not, it will be available for later on. And then what we did is organize the day's proceedings around the key components of survivorship care, which includes prevention and surveillance for recurrences and new cancers, management of long-term and late effects that are physical, management and long-term effects and late effects of psychosocial issues, health promotion, and care coordination. And those are all components that were identified in the original Lost in Transition IOM report from 2006. We did add economic effects since this has become much more of a pressing issue since that time. And the way the day was organized was that after our keynote, we broke into work groups for each of these groups and came up with recommendations, based on discussion, and that's what we will be presenting here. So on this next slide, we did have pre-reading for each of the attendees, which are listed in the left-hand column. One of those is a portfolio analysis that Julia Rowland and others did around the 2016 portfolio on survivorship research. Ron Klein and others wrote a paper that was a summary of a workshop that was held a year ago at the National Academies that looked at the progress that's been made since the original IOM report. And then the American Cancer Society recently published a blueprint for survivorship education, care, and research as well. And so each group was charged with answering the following questions. What are the most important gaps in cancer survivorship care research that needed to be addressed? What are the most important strategic research priorities to address these gaps? And what are the key next steps to generate meaningful progress soon? You saw that Kevin Effinger gave the keynote, and it was meant to be provocative and challenging us to think about where we need to be going about this. And so he identified a number of issues. The one good thing he identified was that the number of NIH-funded studies in survivorship care had been increasing over time, although the numbers shared were still considered low. But the number of K or training awards had increased over the last 10 years from 20 people receiving that award to 43, which helps us think about the pipeline of survivorship researchers increasing. The other identified gaps and challenges in survivorship care included how can the primary care provider be integrated across and throughout the cancer continuum, and there are many issues related to that. And then the impact of long-term and late effects. There have been a number of papers and reports on that in adults, and this conference will be focusing on adult survivors of adult cancers because there's been other work that's been done on childhood survivors and their late effects. So we're focusing right now on adults. But there's fewer intervention studies that have been done and published. The other is that we know that although the number of new cancer patients is relatively flat going forward, and the number of people dying of cancer is declining, which leads to a larger number of survivors, that impact on our healthcare system has yet to be fully felt as more and more survivors need care, and the number of oncology providers will not grow in a same proportion to meet those needs. The other is in general health care, there's a major shift going on that is going from our current system into a value-based healthcare system, and that's currently evolving from an episodic method of care. And then the role of risk-stratified follow-up care, which has been discussed over the last 10 years but has not really been implemented yet in the U.S. healthcare system. And Kevin left us with a challenge of thinking about how could we join forces with primary care through ARC-related practice-based research networks with the NCI Community Oncology Research Program, since geographically, many of them are in the similar geographic areas, to thinking about how can we join forces to continue looking at the follow-up care of survivors and what else is needed with them. So one of the big take-home messages as well in his presentation included the importance of managing the non-cancer-related comorbidities throughout the cancer continuum, especially during treatment, and adherence to medication and management of those comorbidities over time. So he cited some literature and some experiences around that, but really set the stage to help us think about expanding the walls of where cancer care is delivered and by whom as we look at these different phases of and components of survivorship care. And what he shared with us is a continuum that you'll all be familiar with, which is the cancer control continuum, but our conversations were mostly focused in the yellow box on survivorship. And I wanted to identify the cross-cutting themes that were identified by multiple groups throughout the day so that you know that these are issues that we all identified going forward that will apply to many of the topics that we talk about. That include how do we address the research needs, keeping in mind a way to identify and reduce the disparities in survivorship care and how we can promote equitable cancer care for survivors. How can we exploit existing data sets and studies to include survivorship? How to leverage technology for measurement and intervention, the need for multi-level studies while keeping patient-centered, and implementation into the community where most of cancer care is being delivered and where follow-up care is, and how do we develop and implement and test risk-based stratified models for follow-up survivorship care. So those themes will be relevant to all the groups that we'll be talking about. The first breakout group was on prevention and surveillance for recurrences in new cancers. Each of our breakout groups was opened by a cancer survivor or advocate telling their story and talking about why this topic was of importance to them. And it was a way to keep us focused on the needs of survivors and really bring home the relevance of the topic at hand. And Jamie Goldfarb did a wonderful job of that as a 7 or 8 year survivor of metastatic melanoma who benefited from participating in clinical trials. Excuse me. Ron Chen from University of North Carolina was the reviewer of the topic, and then Joanna Elena from NCI reviewed the portfolio of funded research on this topic. We did a portfolio analysis following Julia Rowland's paper, which was 2016, to look at what's in the pipeline from 2017 to 2019 as a way to see what kind of activities were going on in that field. And what they presented was that basically 20% of all new cancers are going to be occurring in somebody with a previous history of cancer, making the prevention and surveillance very important for not only new cancers, but recurrences as well. And that the evidence for these surveillance programs is not as strong as it needs to be as to what should be done in what kinds of patients. And so that there was, and that the existing guidelines that exist, even if they're not as strongly evidence-based as we would like, are not being adhered to at a level that we need them to be either. So those were really two of the big take-home messages: is we need more evidence around the surveillance schedules and the type of surveillance, and then we need to be looking at how do we get people to be more adherent to the screening through the guidelines, and more adherent and consistent guidelines. In the portfolio analysis, that there were 18 grants from 2017 to 2019 that touched on these topics. There were 5 related to prevention of new cancers or recurrences. There were 6 related to surveillance schedules. There were 6 related to methods for doing this, and there was 1 looking at new cancers. And so one of the notable gaps was also the absence of studies looking at tailoring preventative services such as screening or vaccines to the individual survivors' needs that go beyond the general population, whether that's needed and what they need to be. So that was an overview of a very rich session by these 3 presenters. So what the end of the day, after their recommendations and then the group input, the priorities are the ones that you see on your screen now, and they include testing optimal frequency, risks, benefits, and bundled screening, and evidence-based guidelines that are consistent across organizations so that you're not getting mixed messages with many different recommendations, and to look at how to reduce disparities among these different populations being served. And then adding longer surveillance for existing relevant clinical trials. As you know, with many studies, when they end at 5 years, it's an artificial ending point where we lose a lot of the long-term data on some of these studies that might be really useful in survivorship research, and thinking about funding mechanisms to extend a follow-up period beyond existing clinical trials. And then the last recommendation was how do we enhance SEER, state registries, and other national cancer databases to continue ongoing surveillance of survivors further out into the future than currently do. So what we're going to do now is ask you whether how much you agree to those priorities, and we'll give you close to a minute to take a look at that, not only to answer the question in the poll, but also if you feel something major is missing. Again, we put things in the priorities, not that there weren't other more important things, but these are the ones that we felt were the areas where biggest impact could be seen if we could get these things to be moved forward in the survivorship arena. So we'll look forward to seeing what your thoughts are on this.
So it looks like 47% of you strongly agree with the priority areas that we had mentioned earlier. It looks like 40% somewhat agreed, 9% neither agreed or disagreed, 1% of people somewhat disagreed, and then no one strongly disagreed.
For those of you who that didn't strongly agree, if you felt like there are other topics that should be high up on that list, please make sure you add them to the chat questions so that we can capture that. Thank you. So in a similar model, we had a breakout group looking at the long-term and late effects of physical aspects of survivorship care. Craig Lustig is a cancer survivor who works at Georgetown Cancer Center, and he really discussed the many long-term and late effects that he had to learn to live with after his cancer treatment, and really was very powerful in making sure we understood how significant this issue was. Ann Berger from University of Nebraska and Sandy Mitchell from NCI also presented during this session. What they talked about was using the framework of looking at the T1 to T4 framework from discovery to implementation, and identified a number of areas along each way that were very relevant to the physical late effects group. Under scientific discovery, they talked about the need for more biomarkers of treatment late effects and biologic mechanisms and understanding of those for risk factors, as well as genomic risk factors for late effects. Under intervention testing, they wanted to look at particularly the impact of comorbid conditions on the symptom experience and the need to do more studies on supported self-management for patients experiencing physical effects. Under guidelines and policies, they wanted to look at assessing intervention feasibility, effectiveness, and acceptability in real-world settings, moving beyond very tightly controlled clinical trials, and to prompt the inclusion of effective interventions in guidelines, policy, and quality standards as a way to disseminate those. The other area of implementation science was around the adoption of guidelines for survivorship care and best supportive care of symptoms in oncology practice to expand prehabilitation and rehabilitation to maintain and restore function and reduce symptom burden. Of the portfolio that was identified, there were 185 grants related to some aspect of physical, long-term, or late effects and symptom management in cancer survivors. There were a variety of study designs and research methods. But like Julia Rowland's previous review, the predominant survivor population represented were adults at middle age, with little representation of young adults or older adults beyond 65, and that many of these studies were done in breast and prostate cancers. And you'll see that as a theme, that we need to be expanding beyond those two cancers to look at other understudied cancers. And the other is that, like the 2016 portfolio review, the emphasis was on the early phases of survivorship, usually within the first 5 years after treatment was concerned. And that certainly is an issue because our knowledge of late effects may take many years later than that to understand fully what's going on. So we're going to have here listed the priorities for the physical late long-term effects, and that includes measurement of symptoms, functional impairments, comorbid conditions, and needs as core measures by disease, by type of cancer. The profiles of natural history of late and long-term effects in prevalent cancers, and that would be extending beyond those 5 years. And the ability to frame intervention development using the chronic disease model as it's multi-level and is patient and family focused at its core, and spans risk reduction, rehabilitation, and self-management support. So those were the 3 priorities that came out of that group. So we'll look forward to seeing what you think of that.
All right, since it looks like a lot of you already completed the poll, let me push out the poll results. We had 66% who strongly agreed with these priority areas, 25% somewhat agreed, 1% neither agreed or disagreed, 0% neither disagreed on either somewhat or strongly.
Well, thank you, and please make sure if you have other ideas to enter them in the chat box so that we can collect that as well. So the next breakout group we'll be talking about then is the long-term and late effects that are psychosocial. And we all know that this is it's an artificial separation between the physical and the psychosocial, and that there's an interaction, but it was the way to break out for a focused discussion. And in this breakout group, we had Linda House, who's from the cancer support community, as a survivorship advocate, and talking about the long-term needs of survivors that were being addressed. Karen Sorelia from the Fred Hutchinson Cancer Center and the University of Washington, and Paige Green from NCI ran this session and reviewed many of the psychosocial impact of being a cancer survivor. We certainly know that there's a long list of things, including fear of recurrence, distress, anxiety, depression, post-traumatic stress syndrome or disorder, caregiver issues in here as far as caregiver depression and caregiver PTSD, guilt, grief, loss, and identity, issues about returning to work, and then a large group of people who also experience post-traumatic growth or benefit finding from their cancer experience. In a review of evidence-based interventions included things like cognitive behavioral treatments, health coaching and self-management, psychoeducational and information sessions, physical activity programs to help, mind-body programs, and rehabilitation and return to work programs, as well as journaling as being helpful to address some of the psychosocial aspects. In this portfolio analysis, 54 grants were identified. Most of them came from NCI, although in our portfolio analysis, other NIH institutes do fund research in these areas, including NINR and National Institutes of Aging. Most of them were R01s. Most of them focused on breast cancer survivorship, and most included quality of life as a mediator, moderator, or outcome of the study, so the overall broad concept of quality of life. So the group's research priorities identified the implementation of psychosocial interventions in real-world settings, so moving it out of just the very tightly controlled clinical trials, including not only the community and community oncology practices, but also into primary care where these long-term survivors are being seen. And then the integration of psychosocial services and interventions into existing community systems. And another priority was the prevention and mitigation strategies that included risk stratification for identifying and intervening at those who are at higher risk compared to those who are at lower risk. So again, we want to look at your input. Please vote and tell us what you think of that, and then add any other topics that you think warrant being at a high level of priority for psychosocial long-term and late effects.
Platforms correlating all of your answers now. Thank you again so much for submitting your responses during our poll questions and all the chat and Q&A responses we've been getting as well. So from our last poll, 55% of people strongly agreed with these priority areas. 34% somewhat agreed, 4% neither agreed or disagreed, and 2% somewhat disagreed, and 0% strongly disagreed.
Great. Well, thank you. Please, again, remember to add your ideas into the chat feature as we move on to our next breakout group, which was related to health promotion. And our cancer survivor was Brittany Avon, who's a doctoral candidate at Johns Hopkins, who has thyroid cancer, and she's been living with metastatic thyroid cancer for many years, and really talked about the importance of health promotion in helping her maintain her function and continuing on with her planned studies in this area. Karen Basson-Enquist was from MD Anderson, did the review, and Frank Perna from NCI did the portfolio review. In health promotion, we focused on, not surprisingly, things like physical activity and weight management, smoking, and skin cancer prevention as the 4 key components of health promotion for survivors. And in the review that Karen did, using the orbit model of the health behavior translational continuum, it was clear that the greatest amount of evidence was in tobacco use and prevention and cessation programs, and that they were at the level of dissemination implementation. Physical activity, exercise, and weight management were more along the efficacy and effectiveness and some dissemination level of development for those studies. And we were further behind at early phase 1 and 2 trials, looking at associations between behaviors and outcomes and proof of concept and pilot testing for alcohol reductions and skin cancer prevention. There were 27 grants in the health promotion file, and most of these were funded by NCI, followed by NINR and NIA. 41% of the studies were related to physical activity, over 18% on diet and exercise together, and then 11% on the nutrition, and only 3.7% were related to smoking, and less on, I think there was 1 study each maybe on alcohol and sun protection, so very few on those 2 areas. They recommended in the next slide that the research priorities for health promotion include mechanisms and biomarkers for health behaviors, integration of existing and emerging technologies for health promotion and cancer survivorship care, and multi-level research studies addressing health behaviors in cancer survivors. So let's see what you think of those.
Looks like we have a few results still coming in, and we'll be closing out the poll in the next couple of seconds. So submit your answers now. So it looks like 44% of individuals strongly agreed with these priority areas. 43% somewhat agreed, 7% neither agreed or disagreed, 2% somewhat disagreed, and 1% strongly disagreed. So for anyone who disagrees and you have other recommendations, please feel free to type them into the chat and Q&A box.
Thank you, Jennifer. The next breakout group was around care coordination. In this group, just to remind everybody that coordination is about synthesizing care goals and decisions across multiple groups involved in a patient's care, as well as mutually aligning, timing, and adapting key tasks among different care teams or team members over time. And we know that that's a real issue in survivorship care. The group was led by Shelley Fold-Nasso from the National Coalition for Cancer Survivorship, Shauna Hudson from Robert Wood Johnson Medical School at Rutgers, and Michelle Malika from NCI. The National Coalition for Cancer Survivorship had recently done a survey that really identified the gaps that still exist in care coordination and that patients really feel there's poor communication between and amongst their providers, but particularly between the oncology team and their primary care providers. in the review that Shauna Hudson provided, really continue to identify that, that they vary, the pathways vary by type of cancer, and that the breakdowns and coordination of care vary depending on what phase of the care continuum the patient is on. That there's not really very good coordination of survivorship models in primary care, and that survivors are not necessarily viewed as a distinct population in primary care. What's more, the focus is on dealing with patients with multiple comorbidities, many of whom happen to have cancer. Also, the big issue is that practices still feel like there's poor communication with cancer specialists and limited communication to them, and that oncologists are still endorsing a specialist model of care at a time when the volume of patients is growing to the point where that may not be feasible in the future. And that the discordance between cancer specialists and primary care clinicians about knowledge, expectations, and perceived roles continues. In that research portfolio analysis, there were 8 research grants and 2 training grants. So in our next slide, what you'll see here is the identified priorities, which were to identify key outcomes to assess quality care at coordination, and to identify what the optimal models to promote risk-based care coordination would be, and what strategies are going to be needed to support particularly vulnerable populations, and then how to engage IT into this care coordination so that it's more consistent across care settings, providers, and cancer continuum. So let's weigh in on that one and see what you think of that.
All right, we're pulling in the final results of our poll. And again, if you had any recommendations, please submit them in the chat and Q&A box. You were definitely keeping us busy in today's webinar. So it looks like we have 51% who strongly agree with these priority areas, 35% somewhat agree, 10% neither agree or disagree, 1% somewhat disagrees, and then 0% strongly disagree. So it looks like no one really had any disagreement to these.
Great, and we'll look forward to your ideas in the chat box as well. And our last breakout group was looking at the economic effects of cancer. And that was run with Robin Yabroff from the American Cancer Society and Janet DeMoore from the National Cancer Institute. And they really talked about the different aspects of medical financial hardship, that there's material impact, psychological impact, and behavioral issues when somebody experiences financial hardship. It's relatively common, even many years after the cancer diagnosis and treatment, with out-of-pocket spending for more than medical care and consistent evidence about patient risk factors. And that this issue has one of the greatest impacts for widening disparities in the outcomes for cancer survivors. Many characteristics are associated with financial hardship, and those risks include being younger, having lower socioeconomic status, being un- or underinsured, being unemployed or changing employment because of their cancer, being of a minority race or ethnic group, and being in a rural geographic area, all put people at greater risk for economic hardship. In the portfolio analysis, there were 17 grants that examined the effects of cancer. About half of them looked at defining and describing what the financial hardships were. 35% of the 17 grants looked at employment and productivity lost, and about a quarter were looking at insurance coverage, and another quarter at costs of cancer care. The economic issues were looked at both as an outcome and as a predictor. Most studies were observational and through the RO1 mechanism, so we don't have really very many studies yet that are interventional level in this topic. They came up with a number of research priorities that are identified here, including longitudinal studies to understand risk factors for financial hardship, employment limitations, and other economic effects. Studies to understand the impact of financial hardship, employment limitations, and economic effects on functioning, clinical outcomes, quality of life, and healthcare utilization. To conduct new interventions to address economic effects and leveraging implementation science to ensure effective interventions are disseminated. Leverage data infrastructure, linkages, and methods to do other studies, and to leverage technology to collect data and deliver interventions. So please weigh in on these priorities and let us know what you think about them.
So it looks like we had 72% of people who strongly agreed with these priority areas, 18% somewhat agreed, 2% neither agreed or disagreed, 4% somewhat disagreed, and then no one strongly disagreed.
Great, thanks, Jennifer. And don't forget to add your topics to the chat area as well. So right now what we're going to do is see if there were any questions, and we're going to have them addressed so that people have been submitting some general questions, and maybe we can comment on them in the next few minutes before we talk about what the next steps are going to be.
Right. Deb, there's a general question in the beginning. Where do the cognitive effects fit in the survivorship section? They seem to pop up across.
It's a good question, and the cognitive effects could be either in the physical or the psychosocial, but it's really in both. When we talked about it, we did include it in the physical effects, although there are certainly psychosocial interventions that can be addressing that as well. But for this exercise, we put them in physical effects.
Great. In terms of integrating interventions into real-world settings, was telehealth or web visits, for example, the delivery of interventions to the patient's home, discussed at all?
So innovative delivery mechanisms were certainly discussed as something that's going to be needed, especially if we want to close the gap of how follow-up care is delivered, especially in rural areas. But it was not, it didn't end up in the specific recommendation, but it was certainly going to end up in the proceedings in the paper that will come out of this. I think we're going to have to be very creative if we want to close the disparities of access that are created by access to follow-up care using mechanisms like that.
And two more questions, well, three. There's a lack of evidence or consensus-based monitoring guidelines for survivors of adult cancer. Can you comment on how we can implement guidelines if they don't exist and how this was addressed during the meeting?
Well, there are some guidelines on certain things. Some of the guidelines are really applying the general population to the cancer-specific populations, and those ideas need to be tested further. There are other guidelines, like on the surveillance components. We know, for example, that for major diseases, different organizations from the USPSTF, American Cancer Society, and then any of the organizations like the AUA or other groups have different recommendations for surveillance and screening. And we need to think in the broader sense of how are we going to come up with guidelines that everybody can agree to make it less confusing as to what is being offered. And so there's some structure and process issues that needs to be addressed, as well as focusing on the outcome that's going to come of those things. So yes, it's very difficult to apply something that doesn't exist, but even in the areas that do exist, they're not uniformly in sync with each other.
A comment, more research in the education of patients regarding alcohol intake. Alcohol is abundant in advertisement and is a modifiable risk factor. Many women are surprised at the breast cancer and alcohol intake connection. Was this addressed during the meeting, and if so, in what context?
Certainly alcohol is an issue, and it's getting to gain more attention more recently. And as I said before, there was only one grant that actually looked at alcohol intake. It was considered in the health promotion area. And I think that there was some discussion about the need to do multiple health behavior intervention. And that would certainly be one that should be considered in that. The other is that not every cancer is uniformly affected by alcohol. There are some that are higher risk with alcohol intake than others. And so again, getting away from just the breast cancer example, looking at head and neck or some of the other cancers, that may be very relevant in.
And I think a final general question that's come in. While reproductive health awareness could fall into preventative care, it's certainly a topic to be addressed in the long-term effects for young survivors. Any plans for this issue to be addressed?
That's a very good question, and I'm not sure that that came up as a clear signal. So we'll definitely consider that in your chat, from your chat comments. Thank you. Okay. And what we will do is, once we post this, we will also include the survey data and organize the chat comments as well as putting up the slides and the recording of this session. What I did want to do, share with you, is what we're thinking about with the next steps is having taken into account what you're weighing in on, as well as what was discussed at the conferences. This will certainly be developed into a white paper that hopefully can get published in the not too distant future, but also as the Office of Cancer Survivorship looks forward to identifying those priorities and then looking at the different mechanisms that they may be addressed within both NCI and NIH funding opportunities, but then to be also used by other organizations and advocacy groups as a way to address those issues that we think are high priority for this growing population. So I want to thank you for your time, especially for those of you on the East Coast time with taking up your lunch hour, and that we look forward to reading your comments, and we will be sending you an email for having participated, both to get your feedback as to how this went, but also to share the findings further with you. So look for an email and a link for this. Thank you very much for joining us today. I also wanted to identify, and in case you don't know about them, 2 of our newer funding announcements around survivorship research that were recently released, and one is around pediatric, adolescent, and young adults. And then the other is about care coordination, and as you saw, there was very few grants in our portfolio around this, and hopefully this RFA will help identify other opportunities to move that field further along for survivors. And then for general listings of any kind of survivorship funding opportunities, you can look at the 2 links that I have put down here for both NIH and for NCI. So I want to thank you again for your time. I'm certainly open to receiving emails if you have comments that you didn't share in the chats that you would like to. And again, thank you for joining us and sharing your opinions about this.